Proceed, Ziad.
Can you hear us? Hello?
Yes, we can hear you fine, and we can see your screen quite clearly, so proceed.
Okay. We're going to be presenting on TB and MDR-TB in a PhD setting. Okay, I'm going to jump straight into it. So how do we diagnose TB? I think we should all know this by now. So it can be diagnosed on clinical symptoms, radiologically, or the most definitive, obviously, is by bacteriological methods. So clinical symptoms of pulmonary TB is the persistent cough for 2 weeks or more, or any duration in HIV positive patients, and then the constitutional symptoms, a fever for 2 weeks, drenching night sweats, unexplained weight loss, and then other symptoms according to what system is involved for extrapulmonary TB. So with radiological diagnosis, the signs of active TB on an X-ray are infiltrates, cavities, nodules, pleural effusions, hilar, lymphadenopathy, and then miliary titres. So the guidelines we used for this presentation are the 2014 National TB Guidelines and 2019 Management of Rifampicin-Resistant TB. The diagnostic tests we have available are microscopy, culture, and PCR-based tests. So we use smear microscopy. It has a good specificity for TB, but a very low sensitivity in detecting TB in patients with non-cavitatory pulmonary disease. So that's like HIV patients. And the number of acid-fast bacilli that are seen on the smear reflect the patient's infectivity. So the more acid-fast bacilli, the higher the infectivity. Culture is more sensitive than smear microscopy in detecting a higher portion of cases among patients with symptoms. However, it's expensive and has a very long turnover time of weeks. When do we use cultures? So if we suspect that they have pulsy bacillary TB, and they've had 2 negative smears. And then for drug susceptibility testing as well. So people that are TB suspects with a history of previous TB treatment, so either interruption, failure, or relapse. For patients who remain spear positive at the end of the intensive or continuation phase, or who fail to improve clinically during treatment. So basically people we suspect have a drug-resistant TB. Then we have the PCR-based test. So line probe assay is useful for drug resistance confirmation and detects both RIF and isoniazid resistance. And then we have Gene Expert, which is useful for rapidly detecting TB and allows for us to rapidly exclude rifampicin resistance. So for this reason, we use it as a first-line screening test because the turnover is very quick, about 2 hours. So this is the algorithm that we use for when we have a positive Gene Expert results. So what we do is we take a spot, if we suspect TB, we take a spot specimen and then tell the patient to come back within 2 days. So the result is reflected as expert positive or negative. So I'm going to be focusing on positive, and then whether it's RIF sensitive or not. So with RIF susceptible, we start them on regimen 1, and then we take another spot specimen for microscopy, which is used for monitoring, and that will be discussed later. It can also be unsuccessful, so you're not able to determine whether or not it is sensitive or not. In this case, you'd still use the first regimen, the standard regimen, but then you'd have to collect a specimen for microscopy, LPA, or culture and drug sensitivity testing. So then if the results of that show that you have drug susceptible TB, you'd continue with regimen 1. If not, you would go along the pathway of drug resistant TB. And then if you expert positive and RIF resistant, then you'd go along the pathway of drug resistant TB. So that will be discussed. So now you've made the diagnosis of TB. What do you do? So notification, contact tracing, and registration also a very important part of treatment for TB. So notification, TB is a notifiable condition, and notification aids in surveillance of the prevalence of TB and the effectiveness of TB treatment programs. Contact tracing, the ultimate goal is to prevent propagation of TB by identifying those at risk and treating them. For registration, this enables us to categorize TB patients for appropriate treatment and to evaluate the treatment outcomes. So we use a TB treatment record, and the different information is on it. So we would include the site of the disease, so whether it's pulmonary, extrapulmonary, bacteriology, so whatever is used for the diagnosis, so whether it's expert smear or culture results, as well as the smear results from monitoring, and then the severity of the disease. So that's determined by the extent of the disease and the anatomical site. So the disease is severe if there's a significant acute threat to the life, or if there's a risk of serious long-term consequences. So looking at this table, also part of the registration process, we need to note the history of previous TB treatment. And the aim of this is to identify those that are at a higher risk of getting acquired resistance. So the categories are new. So that would be if you haven't been treated for TB before, or you have, but it's been less than 4 weeks. And then we have previously treated, which is being treated for more than 4 weeks. So under that would fall relapse, retreatment after failure, and retreatment after default. In addition, can also be classified to prevent double counting for statistic purposes, whether the patient is classified as moving in by the receiving facility or moving out by the referring facility. So these are examples of the TB treatment records with all the information I've spoken about. So for drug sensitive and resistant. So before starting treatment for TB, we need to do a few baseline tests. So as I mentioned, you do a microscopy baseline test just to see how many acid-fast bacilli are on the smear, and then that's important for monitoring to see if you become smear negative. Also need to work out the BMI, so the weight and the height, and then the weight is really important because you need an accurate weight to determine which weight category the patient would be in for dosing purposes. TB and HIV co-infection is very common. So it's important to know the HIV status of the patient when you're starting the TB treatment. Screening for diabetes is also an important part of TB, of baseline test TB treatment. So all patients would get a glucose and ketones, and then if they're symptomatic, polydipsia, polyuria, we'd also do a glucose to determine whether they qualify, if they meet the criteria for treatment for diabetes. So you also need to do a pregnancy test for women that could be pregnant, so amenorrhea and childbearing age. And then alcohol is screened because that can be a marker of undiagnosed chronic liver disease. And you need to do baseline LFTs for that. And then if you're known with kidney disease, then you do a creatinine. And a chest x-ray is important for people that have other concomitant lung diseases. Okay, so the treatment of the standard treatment of TB, of RIF-sensitive TB, is the 4 main drugs: rifampicin, isoniazid, pyrazinamide, and ethambutol. So as I mentioned, the treatment is it's dosed according to your weight. So the standard treatment is 6 months, 2 months of intensive phase and 4 months of continuation phase. In severe or complicated disease like TB meningitis, TB of the bones or joints, or miliary TB, the treatment may be extended to 9 months. So that's two months of intensive phase with all 4 drugs, and then 7 months of continuation phase with the rifampicin and isoniazid. Adjuncts to TB treatment. So isoniazid has a side effect of peripheral neuropathy. So that's because of the B6 deficiency. So we give pyridoxine, which is B6, at a dose of 25 milligrams daily. If the patient develops peripheral neuropathy at any point in the TB treatment, despite being on this dose, it can be increased to 50 to 75 milligrams, up to a maximum of 200 milligrams until the symptoms subside, and then reduced back to 25 milligrams. Steroids also recommended for TB meningitis and TB pericarditis. High-dose steroid treatments with prednisone, 1 to 2 milligrams per kg daily for 4 weeks, and can be used, and then that's tapered down over 2 weeks. Cotrimoxazole is also used for HIV-infected patients. So special populations. So we have those with liver disease, both acute and chronic, and those with renal impairment and pregnancy. Those with chronic liver disease, you need to do a baseline LFT, as I mentioned before. If it's normal, it's not recommended that you continue doing monitoring of LFTs. However, if it is elevated, you need to determine if it's more than 2 times the upper limit or within 2 times the upper limit. So if it's less than 2 times the upper limit, you'd start the TB treatment still, and then monitor the ALT monthly, basically, to see that you're not developing a DILI in response to starting it. If the LFTs are elevated greater than two times the upper limits, the guidelines suggest that TB treatment shouldn't be started, and the patient should be referred for a workup of why they have an deranged LFT. In acute hepatitis, it's suggested just to seek expert advice. So what they mention is the HIV and TB healthcare worker hotline, which is also an app, so has all the information there that you could use. For renal impairment, so Intern butyl is renally excreted. So we keep the dose the same, but the only thing that we change for the GFR differences is the dosing intervals. So if it's between 10 and 50, then we increase the dosing interval to 24 to 36 hours. And if it's less than 10, then every 48 hours. Pregnancy, use the standard TB dose, as long as there's no other contraindications. And you need to screen the infant post-delivery for signs of TB. If they're asymptomatic, you can use INH prophylaxis for 6 months, and then give the BCG vaccination after the INH prophylaxis. And then in symptomatic infants, you just treat for the TB. Okay, HIV co-infection. So patients already on ARVs can continue with what they're on. There's just special considerations when you're on TB treatment, because rifampicin is an inducer of cytochrome P450. So patients on lopinavir, ritonavir, should have their dose doubled slowly over 2 weeks, so a max of 800 to 200 BD. And then the ALT needs to be monitored weekly while increasing. So you need to continue this dose until 2 weeks after stopping the rifampicin. Another thing that wasn't in the guidelines, but something that we have been doing is dolutegravir, boosting that. So you'd be on dolutegravir 50 milligrams BD. And then the last thing is atazanavir containing regimen. So because you can't double the dose of atazanavir because it's hepatotoxic, you need to change rifampicin to rifampicin if you're on that type of regimen. And patients on third-line ARV should be discussed with an expert. So if you are not yet on ART, if your CD4 count is above 50, it's recommended to start ART after 2 to 8 weeks. If it's below 50, to start within 2 weeks. And if you have TB meningitis, to defer it until 8 weeks.
I am Siphelele Cebekulu. I'll be taking over from Deepo, and I'll be speaking about monitoring of a patient on TB treatment, and also speak about management of common adverse drug reactions. So when it comes to monitoring of a patient on TB treatment, one thing that we need to know is that after initiation of TB treatment, patients need to follow up after 2 weeks and then monthly as well. And I think it's important to document things properly, because a patient is not always seen by the same doctor every time. And then number 2, we need to remember to switch to continuation phase after 2 months as well. And we also need to ask about TB symptoms, check weight, trace contacts, and screen, because you would find that in settings where there's like low SCS, that like 10 people who are sharing one room. We also need to assess side effects as well, because I found that patients struggle to take medication if they're experiencing a lot of side effects. Furthermore, we need to counsel regarding the need for adherence, meaning that the patient must be well informed of what TB is and the medication that they are on. And we also need to counsel about the importance of completing the treatment course. You need to let the patients know about the consequences of not taking your medication. So consequences such as prolonged illness, development of drug-resistant TB, possibility of death even, and continued TB transmission to even other people. And we also need to recommend HIV testing, advise or do pregnancy tests, and also advise on family planning methods. And also not forgetting that rifampicin cross-reacts with a lot of drugs. So if we remember well that rifampicin is a potent inducer of cytochrome P450, so it has a drug-to-drug interaction. So things like COCs and implants are not advisable when you are on rifampicin. And also to follow up on test results, such as your smear cultures that were pending previously. And then I'm also going to move to a more technical monitoring, which is a bacteriological monitoring of patients on TB treatments. So at 7 weeks, it's vital that we take one sputum smear to test. So if the smear comes out negative at 7 weeks, then you commence with the continuation phase of treatment with daily rifampicin and isoniazid at the end of the 8th week of intensive phase. And then you register the patient as negative. You educate and counsel about the importance of adherence. And then after that 7-week test, also at 23 weeks, this is for a negative patient. At 23 weeks, again, you will repeat the sputum smear. And if the patient is negative, then you stop treatment when 6-month treatment is completed, and you discharge the patient as cured. You educate the patient about TB prevention. Also, the same patient who tested negative at 7 weeks, now they are coming in at 23 weeks, you take the smear and they test positive. There, you need to stop the TB treatment. You need to register as treatment failure, and you need to conduct your LPA, which is your line probe assay test, and also your drug sensitivity testing as well. And then, so that's the negative patient who was at 7 weeks. And then still at 7 weeks, let's take a patient at 7 weeks who tested positive. The first thing is you check compliance, you reassess patient clinically, and you send one spot sputum specimen for LPA or culture as well. And you still continue with the intensive phase for 1 month and review after that. And you register patient as positive. You address still with like the compliance and the adherence as well. And with that patient who tested positive at 7 weeks, you repeat the smear at 11 weeks instead of 23 weeks. So you check the culture. If the culture and DST results are negative and drug susceptible, then you change to continuation phase. But if the results are negative and INH resistance, then you continue the intensive phase, you refer to the MDR units, and you register as INH monoresistant TB. And for a patient at 11 weeks who tested positive and has MDR-TB, then you stop treatment, you refer to drug-resistant TB units, and you register as MDR resistance. And then we would move to management of treatment interrupters. We know in our setting, not everyone adheres and takes medication. Some, because of the social circumstances, some they stop and they will tell you, no, I didn't have money for transport, or I was away. I couldn't like travel from KZN, from another province to another province. So what do we do when we have patients like that? So number one is you look how long was the patient not on medication. So if it's less than 1 month, you continue treatment and you add the mixed doses at the end of the treatment phase. But if it's been from 1 to 2 months, you continue the treatment, you don't stop it. You collect sputum for expect and evaluate results. And if the expect comes back positive and reef sensitive, you continue treatment and add the mixed doses at the end of the treatment phase. But with a patient, the expect comes back positive and is reef resistant, then you stop the treatment, and then you register patient as rifampicin resistant. You refer to MDR unit, and you do follow up to ensure that patient has been referred successfully. And then the question is, what about those people who have missed medication for more than 2 months or more than that as well? So you do not start the patient on on treatment. You collect sputum for expect, wait for the results, and evaluate the results. If the expect is positive and RIF is sensitive, then you register the patient as treatment after loss to follow-up, and you restart the regimen, which is regimen 1. And if the patient if the other is, or if it's a different scenario where the expect is positive and RIF resistant, then you register patient as rifampicin resistant TB, you refer to MDR units. And just to emphasize that we must make sure, or we must ensure that patient has been referred successfully as well. And then what about those patients who refuse to continue treatment with every effort that we make? So those ones, we must try and convince them, but if we fail, we must insist and tell the patient that they should sign a refusal of hospital treatment form when you have failed on your part as well. And I think it is important for the interrupters to address the problems or concern and counsel the patient non-judgmental, like in a non-judgmental manner. And then I will continue to the management of common adverse drug reactions to TB drugs. So what I found is that most patients, they stop taking TB treatment just mainly because of the side effects. And I think if we can address the thing of side effects, then we will be able to sort out a lot of things. So with rifampicin, the side effects can be anorexia, nausea, and abdominal pain as well. And the most important thing is to look out for red flags if a patient comes in complaining of anorexia, nausea, and abdominal pain. So you need to exclude drug-induced liver injury, hepatitis, and other causes of GIT intolerance. So is the patient drinking alcohol, or is the patient on chronically on NSAIDs as well? And also you need to exclude things such as esophageal reflux and also pancreatitis as well. And the second culprit, which is pyrazinamide, patients usually complain of joint pains. So with that one, you don't stop the TB treatment, you treat symptomatically with the NSAIDs. And if there are signs of acute gout as well, you treat with coclizine as well. And then isoniazid, and I'm sure a lot of us we prescribe pyridoxine 50 to 75 milligrams daily, and you can increase to 200 milligrams daily in HIV positive patients. Also with rifampicin, with all these side effects, and these side effects are on SA HIV TB hotline. It's an app, you can download it and just read more about it. But it's just important to reassure patients that the side effects that they're experiencing are common side effects. And then coming to one of the most important things, which is adherence. How do we assess adherence? So one, we can do it directly and do a pill count, or just look at, because sometimes when you look at the prescription, you can just see the frequency of prescription refill, and you can see that the patient has not been coming in for their meds, and then you can address the issue. Or you can ask questions in terms of adherence. Ask questions. Do you sometimes forget to take your pills? Asking a patient, how often do you have difficulty remembering to take your pills? And also you can even ask, when you don't experience any symptoms, do you stop taking your medication? Because some patients, once they stop experiencing any symptoms, they hardly take their medication. So you also need to encourage patients that even when you feel well, you still need to continue taking your medication. So here, I've just got 5 dimensions that affect adherence. One is healthcare system related. The second one is social and economic. The third one is patient related. The fourth one is therapy related. The fifth one is condition related. With the healthcare system related, I'm not sure if any one of us would hear patients saying, I no longer go to that clinic because the sisters there or the doctors there are not nice and they don't treat patients nicely. And we forget how that can affect patients' adherence as well. So it's the patient-provider relationship, It's the long waiting times as well, being on the queue. Patients don't like waiting, and lack of care or continuity as well, and also restricted formularies as well. So we need to explain to our patients, simplify everything. Even if it means you need to write it down for them, we need to do that as well. And the last thing that I'll be talking about is adherence aids. So we must try as much as we can to assist our patients in making sure that they take medication. So one of the things that I usually tell my patients is your alarm clock, personalize your alarm clock, that when it goes off at 8, you know that you need to take your medication. Also, medicines chart as well, and pill boxes as well. So patients who can afford to buy pill boxes, they're available at clinics and different outlets as well. Just advise them that they can buy it as well to make life easier for them. And also, another one is therapeutic changes as well. I think with TB treatment, it's good that we don't change the regimen as much unless there is like TB resistant or other factors as well. So it's important to simplify dosing as simple as possible. And if we're explaining to patients, don't say you're going to take 5 milligrams per day. Just take 1 tablet or 1.5 tablets a day. So I will pass over to Ziad to talk about MDR-TB.
Okay, hi guys. I know we're running short on time, so I will try and make this as quick as possible. But basically, so there've been some changes recently in terms of the MDR treatment. There's been a push for decentralization where more patients are getting outpatient care and admissions only based on clinical need. And nurses take over initiation of uncomplicated drug-resistant TB patients. So in terms of outpatient care, some things you should think about is if patients ambulant, in relatively good condition, not wasted, reliable, and willing and able to attend the clinic regularly. That be financially or anything else. And then when to refer, which is quite important in the PH setting as well. If the patient's in respiratory distress, the HB is less than 8, they're wasted, any evidence of CNS disease, clinically unstable social factors, they are non-ambulant, or they've had recurrent treatment interruptions. So the approach to MDR-TB is basically, well, we base it on our gene experts. So say it comes back as rifampicin resistant. Then we send it off for drug-resistant TB reflex testing, which includes smear, culture, first and second line probe assay testing, and phenotypic drug sensitivity testing. Then we assess for any risk factors. So whether they've been on treatment before with any second line drugs, whether they have any extrapulmonary TB, contact with any XDR-TB patients, whether they're younger than 6 years, extensive disease on chest x-ray, or whether they have a singular or both INH mutations on the live probe assay. So if the answer is no to all of those, as well as the HB being above 8, then we can start the short course, which is a packaged sort of treatment program and doesn't really allow for any changes. If they have any of those risk factors, then you start them on the longer course whilst waiting for the reflex testing to come back, which includes mutations to INH, resistance to fluoroquinolones, injectables, bedaquiline, anything. So as I said, the short course regimen is basically, it's generally 9 months, but can be continued up to 11 months, depending on the clinician. So it's 4 to 6 months of intensive phase and then 5 months of continuation, and it includes linezolid, bedaquiline, high dose isoniazid, levofloxacin, as well as clofazimine and pyrazinamide and ethambutol. So as you can see in the pictures, basically linezolid is stopped at 2 months, high dose isoniazid is stopped at 4 months, depending on your blood results, obviously. And there are lots of many other different factors that sort of influence on whether we continue with the short course regimen and when we stop certain drugs. And as you can see on the side, which I'm not going to go through because of our running short on time, are some adverse effects of some of the second line TB medication drugs. The longer regimen also generally contains at least 5 drugs, and it starts with sort of bedaquiline, levofloxacin, linezolid, tioridazine, and clofazimine. However, it's generally individualized according to the drug resistance testing, based on resistance and mutations. So for example, if it's a fluoroquinolone resistance, then you can replace levofloxacin with dilaminid. And this longer regimen is generally given for 18 months, but can be extended up to 20 months at clinician's discretion. The intensive phase for this is 6 months with a 12-month continuation. The exception is CNS drug-resistant TB, where there's a longer intensive phase of 12 months with a 6-month continuation period. So the WHO has created this table basically where they group their drugs into group A, B, and C. Group A, you should try and include all 3 medicines as far as possible. Group B, you should also try and include those 2 medications as well. And then group C is basically to complete your longer regimen if there's based on resistance and mutations based on drug susceptibility testing. And then, so if you're culture positive at 4 months, you also are likely to have failed your treatment program, and thus you may require a rescue regimen. And here you have an extended drug susceptibility testing, as well as being referred to provincial or national clinical advisory committees for input, which is sort of beyond the scope of primary healthcare and would generally be referred upwards. Just talking about some special populations, so like children, they may require induced freedom gastric aspirates as for normal TB. Children under the age of 6 cannot get the shorter regimen, and they will require dose adjustments. We try and avoid injectables at all times with children, and should be managed preferably by a clinician with experience in pediatric drug resistance TB. Speaking on that, children older than 6 years can get the shorter regimen, as well as pregnant women, going on to the next thing, and HIV positive patients with a low CD4. So pregnant and breastfeeding women, so all attempts should be made to prevent pregnancy in drug-resistant TB. This is because most of the drugs have been shown to not be beneficial for the growing fetus. So pregnant women still qualify for the shorter regimen. Breastfeeding should still be encouraged, and at all costs, medication should not be used due to the chances of fetal ear toxicity. It's not on the slide, but just something to remind yourself about. HIV positive patients. So if patients are on efavirenz, they should not be given bedaquiline. And if patients are on zidovudine, they should not be given linezolid due to bone marrow suppression. If patients are ART naive, then it's as for normal TB. And then just quickly going through TB outcomes. We've touched on it before, but the main 6 TB outcomes are cure, where the baseline smear was positive at the beginning, and then they smeared negative. Treatment completed is where you don't have that last smear available to you, whether it hasn't been done or whether the results aren't available yet, it depends. Treatment failure is those patients who have a smear positive post 5 months, obviously patients who have passed on, defaulted, and then transferred out, where basically you don't know what their outcome was. So thank you guys, sorry for going a bit long, but yeah, does anybody have any questions?
Thank you. Great stuff. Always neat. Any questions? Any comments? These are intended to be short, half-an-hour presentations. It cannot be in any way comprehensive completely. But I'm always struck by the fact that you guys put together, what you think quite important, and they're actually very neat reminders of what you sort of have done before many, many times, but with the spin on it, sort of saying, well, this is what I need to know in the primary care context, and that we need to sort of remember and navigate. So always handy, and I'm sure you guys will find that in future handy. The presentations will be up on the website. They are there already. So it'll be always a useful resource for you. Any other comments? Michelle, any comments? I'm not sure if she's still with us. I think she's left. All right, guys, well done. I think we finished on time, just a few minutes to spare. The presentations, recordings are all on the website. The cases are also there. I think there's one that I'm missing. If you can just send it. And we should be able to do these cases sometime in the next few weeks. We'll just see how best it works. Perhaps you guys can just give the last group a rating, and then we can end. Great. While you're busy rating, MDR-TB just literally a few years ago was managed completely with in-hospital care. And you can imagine someone being literally put away for 2 years almost, and in hospitals. It was not a very good environment, and many patients actually rebelled, saying, you actually are keeping me inside, limited away from my family in a very difficult environment, work affected, etc., etc. And I think the growing burden of MDR-TB, it made it such that this is unsustainable. And so this approach has been to try and manage it outpatient based, and it is becoming a common common phenomenon. So please be familiar with how to manage it. It is most of the time that you need to prescribe, and the rest of it's managed by nurses. But you need to be managed the initial the sort of initial and perhaps a few here and there consultations, and you need to be familiar with it. So let me end the poll and share your results. Good to very good. Thank you all very much. We will talk to all of you next week. Take care, everyone.